Client Coding Systems Coding Academy welcomes you to our presentation, Introduction to Risk Adjustment and HCC Coding. 1 AAPC CEU will be available for viewing this presentation, and we'll have details on that at the end of the presentation. We would like to note that risk adjustment and HCC coding is a very deep knowledge base. It cannot be learned in an hour. This is an introductory overview presentation and is not intended to be a complete course or explanation. However, if you are interested in furthering your knowledge, Compliant Coding Systems has been offering training since before there was a certification. And at the end, we'll have an email address that you can contact us if you'd like to engage in further training. I'd like to ask a question. Where do medical providers receive their operating revenue? Primarily insurance companies, correct? Payers. So if your organization sees payers as this, it would be prudent to fertilize that money tree. And hopefully by the end of the presentation, that slide will make much more sense. So just a quick overview of risk adjustment. What is risk adjustment? Based on health status, it adjusts some financial component of the cost of healthcare coverage. And you see I have that highlighted in yellow. We'll talk about that more in a second. What and how depends on the coverage, and that will become clear by the end of the presentation. I have a note here, and we'll reiterate this on some subsequent slides, but risk adjustment is associated with the cost of providing healthcare benefits, or insurance, if you will. It is not about claims processing or payment, which is the responsibility of the organization that provides the risk-adjusted coverage. So let's break that down and explain that. Again, this is not about claims payment. This is not about a hospital or a doctor submitting a UB or a 1500 to an insurance form. That is not risk adjustment, okay? Risk adjustment is where these risk-adjusted payers under risk adjustment methodologies get their revenue to administer health benefits, okay? So in the Medicare and Medicaid models, it's the money that the federal or state governments pay these carriers to cover a population of beneficiaries. Same is true in the commercial risk adjustment world. It just works a little bit differently, and we'll touch on that a little bit later in the presentation. One of the essential elements of risk adjustment is predictive modeling. Okay, so I'm going to give you a brief explanation of what predictive modeling is. We have Chris. He's 18. He just graduated high school, and he works as a server in a restaurant. We have Jan. She's 32. She's a mother of two, and she works as a senior manager with an accounting firm. So Chris and Jan just went downtown to the local car dealership, and they bought the exact same model car. They paid the exact same price. They had different APR on their loans because, well, Jen had more of a credit history. But they went down to the same dealer, bought the same car, same price. So now they need to insure their new cars, and they called the same insurance company. They made that 15-minute call, right, to Geico. And they were both quoted rates to insure their new car. Chris was quoted $199 a month. Jan was quoted $99 a month. Why? Predictive modeling. You see, Chris is a young man, young male. He has had a little bit of a traffic offense. He lives in a zip code in town that is not quite the same as Jan's, And when all of this is factored in, uh, Chris's quote for auto insurance was higher, where Jan is, older, female, lives in a different zip code, but less crime or less risk, etc. All of these factors are predictive modeling. Okay. The auto insurance company looks at all these different factors and determines the risk involved in insuring Chris or Jan, right? And the same applies to healthcare and many other areas in life. But for today's presentation, we can apply this to healthcare, and hopefully we'll be clear on that by the end of the presentation. Just want to talk about some different risk adjustment models. A lot of people hear HCC coding, okay? HCC is one model in risk adjustment. There's a reason why it's the common term, and we'll talk about that a little bit throughout the presentation. But the three major payer categories all have risk adjustment models in play: Medicare, Medicaid, and commercial. And so here's just a little graphic on the payment structure or the payment channels for each. In Medicare risk adjustment, the payment is from CMS or from the federal government to the MAP or Medicare Advantage plan. And we have a thing called a risk score, which we'll talk about. And that is factored down to the beneficiary level, and we'll illustrate this. In the Medicaid model, okay, the payment is from the state to the MMCO or Medicaid Managed Care Organization. And the key risk score is, each individual has their risk score, but it's the overall population risk score that is key in the Medicaid model. And then in the commercial model, and I said that was a little bit different, it is really a shift of funding from plan to plan, okay, that is key. And that's where commercial risk adjustment differs a bit from the other models. And what it is that the inequality in risk is leveled out by lower risk plans subsidizing higher risk plans. Okay, and we'll talk about that a little bit later on. And the risk score is calculated down to the population. The population's overall risk score is the determining factor. Again, in the Medicaid and the commercial models, each individual has their risk score, but it's the population risk score that is the driving factor. Just some characteristics of different models. Some models are based on tiers of severity or categorical. Some models are based on distinct categories with hierarchical subcategories which become additive, and we'll talk about that on subsequent slides. Some models only consider chronic conditions. Some models include acute and chronic conditions. Some models provide for prescription drugs and some do not. So these are just some different characteristics of risk adjustment models that is worth understanding at the deeper level, should you be interested. So as I mentioned, the term HCC is commonly used in risk adjustment, and there is a reason why. Medicare is a national federal program, applies to all 50 states. It has been around since 2004, the risk adjustment methodology under HCC. So it's the longest standing. It is coast to coast. It's all 50 states, and it has become the most commonly known, and it uses the methodology called hierarchical condition categories, or HCCs. Okay. And so for today's presentation, we're going to focus primarily on the HCC model for Medicare. Just a note, and we'll talk about it a little later on, the commercial model also uses an HCC model, which is distinctly similar, but also distinctly different. But that also uses HCC, and the commercial risk adjustment was instituted in 2014, so a decade after the Medicare HCC model was. But when we talk about people using the term HCC, it stands to reason why it's also a commonly used term, because the commercial model uses an HCC model as well. But I do want to talk for a moment why virtually every medical coder should know risk adjustment and HCC coding, okay? And it has to do with a transition that is in place. It's going on now, okay, where provider encounter data will be received unedited by CMS. Providers will be accountable for accurate coding, and risk adjustment knowledge will be applicable to all providers, okay? And we're going to talk about this, some more details on this throughout the presentation, but again, it is essential. It's becoming essential for virtually every provider to have staff that understands risk adjustment, and therefore it is wise for each medical coder to have at least a working understanding of HCC. There is a certification for it, and that is certainly a suggested goal. You don't necessarily have to have the certification, but it would certainly be wise to have a very firm understanding because providers are going to be looking for coders that understand the risk adjustment model. So as I mentioned there, provider encounter data, okay, and you can see here from CMS that using diagnoses from encounter data, okay, and I've pointed an arrow there, okay, and we'll talk about this a bit more. You'll see a note 2, Medicare Advantage organizations, prescription drug plan sponsors, and other interested parties. And included in those other interested parties would be any provider that sees Medicare beneficiaries, okay? And you're going to see here, CMS's goal is to transition entirely from using diagnoses submitted to RAPs to using diagnoses from encounter data, and we intend to continue transitioning away from a reliance on RAPS data for calculating risk scores. Now, I have some slides that will illustrate what this transition from RAPS to encounter data is. Before we do that, I just want to highlight here a question that was submitted to CMS and what the answer is. Currently, a plan may scrub certain diagnosis codes prior to sending the RAPS file. For example, if a member has a history of breast cancer, but the provider submits a diagnosis of breast cancer, which would be active breast cancer, should plans continue to scrub diagnosis codes for the encounter data system? And the answer from CMS was MAOs should submit, and that's Medicare Advantage organizations, should submit encounters as they are received and should not conduct any additional filtering or scrubbing processes. So folks, what this means and what this question was regarding is these Medicare plans that are receiving claims data from providers, okay? CMS has instructed these plans to send that claims data to CMS unfiltered, okay? So let's talk about this, the RAPS and EDS. This is the old way, where insurance carriers would request records from providers. Medical coders would go through those records and pull out the diagnoses for risk adjustment and then submit them to CMS. So this was filtering, this was scrubbing, and really it meant that to a certain degree there was a higher accuracy of valid diagnoses being submitted to CMS, okay? However, we are now in the era of encounter data submission, or EDS, okay? And so the providers are submitting claims to the insurance carrier, and the insurance carrier is forwarding that data to CMS for risk score calculation, okay? And so providers, however they document, however they code, they are committed to that. If they are documenting and coding inaccurately, that information is being sent to CMS. So very important to understand. And so now coders that were reviewing records strictly for the insurance company for submission through RAPs are needed at the provider level to assure accurate documentation and coding. So this is going to create abundant opportunity, but also abundant responsibility. I want to introduce you to Ozzy and Harriet. They're going to help us demonstrate a little bit about Medicare Advantage and Medicare Part C. They were on Medicare Part A and Part B, okay? But they had some options, including Medicare Part C or Medicare Advantage. And this is a commercial managed care insurance authorized by Medicare. So they elected to be covered under this option. So they no longer have Medicare Part A and Part B, but now they are covered by Medicare Part C, Medicare Advantage. So claims are not being submitted to Medicare Part A or Part B. They are being submitted to a plan, which oftentimes is a recognizable name, you know, the Blues, you know, some of the major insurance carriers, but even some major regional health systems have their own Medicare Advantage plans. But now they are covered by a managed care plan through a commercial carrier, okay? And so now CMS pays that Medicare Advantage plan a premium each month to cover Ozzy and Harriet, because now CMS and Part A and Part B are no longer paying those claims. This health plan is. So CMS is going to purchase essentially insurance for these beneficiaries. The health plan uses that premium to pay for Ozzy and Harriet's health services in place of traditional Medicare, in place of Part A and Part B. So remember, I said this is not about claims payment. Risk adjustment is about how much premium the Medicare plan that is now covering them is going to get to cover Ozzy and Harriet to pay providers for their health services. The health plan does not receive the same premium for Ozzy as they do Harriet. Let's explain why. See, Ozzy, he's rather healthy. He sees his physician once a year and has a clean bill of health. He really doesn't have any health conditions to speak of. Harriet, she's a different story. Harriet has diabetes and uses insulin. She has COPD and requires oxygen. She has AFib, requiring anticoagulant therapy with regular monitoring. So Harriet is costlier to cover for health expenses. She's going to have more claims, more, more substantial health bills, right? And this Medicare carrier is going to be paying more to cover Harriet, correct? So CMS pays the health plan more for Harriet based on her health conditions. This is adjusting the premium due to her risk, or risk adjustment. How does Medicare know how much to pay the health plan? This is based on documentation from her medical providers that support her conditions. Okay, and this is where the medical coders come in and are pivotal. Does Medicare go through every patient's record individually? No. Medical coders do. Specially trained medical coders. So let's talk about HCCs, okay? On the left-hand side, you're going to see major categories, okay? And we're going to talk about this a couple different ways, but you'll see major categories: infection, neoplasm, diabetes, metabolic, liver, gastrointestinal. And you're going to see HCCs in the next column, okay? HCC 1, 2, 6, 8, 9, okay? And you're going to see the description. HCC 1 is HIV/AIDS, septicemia, opportunistic infections. The next 5 you'll see are cancer related. The next 3 after that are diabetes related, and so on and so forth. So you can just look down this list, and these again are categories, not specific diagnoses, but categories. Okay, and it goes on. And again, these are categories, not individual diagnoses. There are 26 categories. There are 86 HCCs, which I'll illustrate in a moment. But there are over 10,000 diagnosis codes that risk adjust. Okay, over 10,000 codes, individual specific codes. So let's take a look. And I had mentioned the neoplasms and the diabetes. Okay, these are categories. Okay, and in the category of neoplasm, which is a single disease group, there are 5 HCCs. Okay, over on the right hand side, the diabetes is a single major disease group. There are 3 HCCs. Okay, in the neoplasm, you're going to see, let's work from the bottom up: breast, prostate, and other cancers and tumors, okay, up to metastatic cancer and acute leukemia, okay. A patient may have a diagnosis that fits in one of these categories, or they may be unlucky enough to have 2 different types of cancers. They may have prostate cancer and may have lung cancer. Okay, so they may have a diagnosis code that fits in the category HCC 12. They may also have a second diagnosis that fits into category HCC 9. And we'll talk a little bit more about that in a bit. And when we do, diabetes is a good one to illustrate this. Okay, we have diabetes without complication, working from the bottom up, diabetes with chronic complications, and diabetes with acute complications. Now, I think it would be understandable. I think it's easy for you to understand that you cannot have a diabetic without complication in the same patient that is a diabetic with a complication, right? In other words, a diabetic who has developed chronic kidney disease or neuropathy is no longer a uncomplicated diabetic. They now are a diabetic with some manifestation, right? So HCC 19 would be a diabetic who has not developed any manifestation of the disease, up to diabetes with some chronic complications such as CKD, peripheral neuropathy, circulatory, vision, disturbances or problems, or diabetes acute complications, diabetic coma, or what have you. So there are 3 HCCs in the diabetes group. Okay, so I mentioned there are 26 disease groups, and you saw these groups where we had the listing of the HCCs, but this is just the disease groups. Okay, and how many HCCs are there for each disease group? And you'll see on the left-hand side, if you look under major category, let's skip over infection, but we just talked about neoplasm. There's 5 HCCs. Diabetes, there's 3 HCCs, as we just illustrated. Okay, so out of these 26 major disease groups or major categories, there are 86 HCCs. Okay, and so let's move on and talk about this. When diagnoses are within the same hierarchical structure, okay, and remember we looked at the neoplasm category with 5 HCCs, the diabetes with 3 HCCs. it will only be the highest weighted or most severe condition within that hierarchy that will count towards the risk score. Okay, so this is what's called a trumping table. Okay, and so you'll see on the left hand side, if the uh, patient has a HCC of 8, okay, metastatic and cancer and acute leukemia, then that will supersede, override, or trump HCC 9, 10, 11, and 12, which are the remaining HCCs in that hierarchy or in that structure, okay? And you'll see if they don't have HCC 8, but they have HCC 9, that will supersede 10, 11, and 12 if the patient has a diagnosis in those categories. So let's just go back a little bit to here, to this slide, okay? And a patient may have a diagnosis especially in the neoplasms and other categories, they may have a diagnosis that fits into 2 categories, but in the hierarchy of the category, it will only be the highest weighted or most severe condition. We talked about diabetes, where you can't have a complicated diabetic and an uncomplicated diabetic in the same patient, but in the reporting period, the patient may have an acute complication on top of chronic complications, and that acute complication would supersede the existence of their chronic complication. Okay, and so let's move on. And so I was talking about weights. Okay, the highest weighted. All right, and you will see a column on the far right with numbers in it. Okay, so let's look at HCC 8, 9, 10, 11, and 12, which are your cancers. Okay, let's look at HCC 12. Let's work from the bottom up. HCC 12 has a value of 0.146. HCC 11 has a value of 0.301. HCC 10 has a value of 0.677. HCC 9 has a value of 0.970, and HCC 8 has a value of 2.625. Let's look at the diabetes section, okay? Diabetes without complication, HCC 19 has a value of 0.104. And you will notice that HCC 17 and 18, diabetes with chronic complications and diabetes with acute complications, have the same value, 0.318. And that is an anomaly. That is, there's only once or twice that happens at this moment in risk adjustment. The reason there are 2 categories is when these weights are recalculated, at some point, those 2 numbers could actually be different. Okay, it's just a coincidence that they're the same at the moment. Okay, so these are weights. Okay, each HCC has a weight. Okay, and each HCC has a hierarchy structure, as we looked at. Neoplasms, there's 5 HCCs. Diabetes, there's 3 HCCs. And you see I have highlighted here, okay, some HCCs. Okay, if a patient has HCC 6, HCC 18, HCC 22, and HCC 28, okay, we would add the values of each of these weights together, because each of these highlighted HCCs are different categories, okay? So if we look at HCC 8 through 12, we would only count one of those categories in 8 to 12, okay? Or let's look at HCC 18 that I have highlighted, okay? HCC 19, 18, and 17 are all 3 diabetic category, diabetic HCCs, but only the most severe or higher weighted category will count when there is a hierarchy. So remember I said you can't have a diabetic without complication in a patient with diabetes with a complication. So we would not count diabetes without complication if the patient has, say, chronic kidney disease, et cetera. We're going to get the higher weighted HCC. Okay. And again, when categories exist, when HCCs exist that are not in the same hierarchy, the weights will be added together. And we're going to calculate a risk score a little bit later on to demonstrate this. And let's talk about this risk score calculation. There are 4 parts to a risk score in the Medicare risk adjustment model, okay, the HCC model. Demographics, condition categories, which would be, again, this slide here. This patient has 4 qualifying HCCs. So in the conditions category, we would add together those 4 weights. Disease interactions and count of payment conditions. So let's break this down. Ozzy and Harriet are back. Okay. Let's talk about condition categories. Ozzy, remember, he's healthy. He has no cats, no categories. Okay. And remember, Harriet has 3 cats or 3 categories: diabetes, COPD, and AFib. Okay, so she's got conditions that fit 3 different categories of the 26. Let's break that down a little further. First of all, let's talk about demographics. Demographics is, plotted out on a grid such as this, and it is determined by gender, age, original reason for entitlement to Medicare benefits, and whether the patient is out in the community or institutionalized, and whether they have dual eligibility for Medicare and Medicaid, and further, whether it's partial or full benefits. Okay, so it's as simple as determining these factors and plotting, finding where the patient falls on this grid. Okay, so let's say Harriet is 75 years old and she aged into Medicare. Okay, so I'm going to use my cursor here. She's 75 and she aged into Medicare. So her demographic score would be 0.451. Okay. You'll notice from 0 to 64, there is no value in the aged column. That's because a patient or beneficiary cannot age into Medicare until they're 65. So if they are 64 or younger, the only logical reason for original reason for entitlement Medicare would be disability. And so anybody, and you can see after 65, there's no value in the disabled column, because once you're 65, you've aged into Medicare and you can't be initially eligible due to disability. Okay, and you'll see, the 6 columns here start with community. These are people who live out, whether they live at home, live with family, whatever, but they are not institutionalized. And then there's different values for dual eligibility, and that is FB dual, full benefit dual eligibility, or PB dual, partial benefit dual eligibility. And again, different columns for whether they were aged into Medicare or based on disability. And then there's one value for those beneficiaries who are institutionalized. So that is your demographic component to calculating a risk score. Okay, so let us take a look at Harriet. Remember, she had 3 conditions. Okay, and we have the condition category component here. Remember Ozzy? Ozzy has no health conditions, so he's not going to have a condition category component. Basically, he's only going to have the demographic component. But we have Harriet, who has HCC 19. She's diabetic without complication. Okay, so that qualifies for 0.105 weight for that category. She has AFib, which is HCC 96 for specified heart arrhythmias, and the value for that will be 0.268. So that'll be added to the diabetic weight. And she has COPD, HCC 111, and that value is 0.346. So we're going to add those three numbers together for her distinct conditions, and that is going to be a factor under the condition categories. Okay. There is a third category called disease interactions. Okay. And you'll see in that middle column, immune disorders and cancer, congestive heart failure with diabetes, congestive heart failure with chronic obstructive pulmonary disease, congestive heart failure with renal disease. When conditions that are in this grid exist together, okay, there is going to be an additional weight added or factored into the risk score, okay? Let's look at congestive heart failure and diabetes, the second row there, okay? There is an HCC for congestive heart failure and a weight correspondent to that, and diabetes has a HCC and a weight that corresponds to that. And so those two individual weights will be factored under those condition categories, okay, in that second component. But there will be a third component, this disease interactions, a third value plugged into the risk score when these interactions exist, okay? And finally, number of payment conditions, okay, is the fourth square in the risk score calculation. And so you will see, let's look at the rows D1, D2, D3, okay? If the beneficiary has 1, 2, or 3 HCCs, there is no additional value plugged in. When we get to 4 HCCs, 5 HCCs, 6 HCCs, you're going to see on the right-hand side an additional weight, okay? So the number of payment conditions will influence the overall risk score once we get to 4 HCCs or more, okay? So this is how we calculate a risk score. Let's do this. Let's calculate a risk score. Okay, let's use Aussie, and I selected a demographic value off of the grid. Okay, and it was 0.394. He has no condition categories, so there's not going to be a value for that. If he doesn't have any condition categories, there's not going to be interactions, correct? And he has no payment conditions to count. So we are going to look. We're going to use a factor of $900 as an example as the base payment rate. Okay, so we're going to take his risk score of 0.394, and we're going to multiply that by the base payment rate of 900, and that comes out to $354.60 PMPM. PMPM means per member per month. So the health plan is going to receive $354.60 each month to cover Aussie, okay? So CMS, or the federal government, is going to pay Aussie's Medicare Advantage plan $354.60 to cover him in place of Part A and Part B, okay? So let's look at Harriet's risk score. And we're going to do Harriet's two ways, okay? We're going to do it the way that we presented Harriet, okay, with her 3 conditions, okay. So I selected a sample demographic category for her, came out to 0.386. We're going to add together the 3 HCCs, okay, the diabetes, the COPD, and the AFib, and that was 0.105, 0.268 and 0.335. Okay, so she doesn't have any disease interactions, and she only has 3 HCCs. Remember, we need 4 to get to start adding a value in the condition count payment. And so when we add her demographics and her condition categories together, her risk score is 1.094. And we're going to use the same base payment multiplier of $900. And when we multiply 1.094 with $900, it comes out to $984.60 per member per month, or $984.60 is the monthly premium that Harriet's health plan is going to receive for covering her. Okay, and from that, they must pay all her claims, etc. So, what was Ozzy's monthly premium? $354.60. Okay, and Harriet's is $984.60. Okay, based on the conditions that she has. Okay, now I want to calculate Harriet's risk score another way as an illustration. Okay, let us add congestive heart failure. Okay, let's say she has congestive heart failure. Remember, she has diabetes, and so that's going to be a disease interaction. So we're going to have her demographics. We're going to have the 3 HCCs that we looked at just a moment ago, plus the additional value for the congestive heart failure. Remember, congestive heart failure and diabetes are in an interaction, and that's going to be 0.121. And now we're at 4 HCCs where the payment condition count factors in. And so we're going to have a value there. Okay, so when we add up all 4 squares, her risk score is now 1.552. Multiplying against that $900 base rate, now the monthly premium paid to the health plan for Harriet is going to be $1396.80 per member per month. Okay, or $1396.80 per month is what the health plan is going to receive to cover Harriet. Okay, so you'll see that the accurate reporting of conditions influences how much premium the carrier is going to receive to cover beneficiaries. And the sicker the beneficiaries, the more costly they are, and the more premium a plan should receive due to the increased cost of covering those beneficiaries. So there's no room for mistakes here. Okay, if you are on the operating table, you want your physician, you want your surgeon to be accurate, don't you? Okay, and so wouldn't you want, as a payer, want your providers to report accurate information so that the resources to cover beneficiaries is correct? Okay, and so we have the little false and true. We need accurate information. Okay, the health plans need accurate information from the providers to remain solvent. Okay, and specificity is one of the keys to accuracy. Okay, a very common diagnosis that risk adjusts is major depressive disorder. Okay, and you're going to see here, this is, remember I said there were 10,000 codes that risk adjust? We looked at 26 categories. We looked at 3 slides that listed those 86 HCCs. Okay, here's another level down to the diagnosis code. Okay, and there's 10,000 diagnosis codes that map to those 86 HCCs that come from 26 different categories. Okay, so major depressive disorder, single episode, unspecified. You will see there is not a value in the HCC, okay, because it's unspecified. We need the episode and the severity for it to risk adjust. So you have a note from a physician that just writes MDD. That is not sufficient documentation, and that will impact the amount of money the health plan should be receiving to cover that beneficiary. Okay, so specificity and accuracy is key, is essential for risk adjustment purposes. Okay, and this is why providers are going to be seeking coding professionals with knowledge of risk adjustment. There are audits, okay, that go on, okay, and the primary audit, you've heard of RAC audits and stuff like that. Rad V is the audit process for risk adjustment, okay, and it's the plan that is audited, okay, but the plan will be audited based on information from providers. Okay, so remember that. So let's look at the cycle here. A plan is notified of a Rad V audit. Rad V stands for Risk Adjustment Data Validation. Risk Adjustment Data Validation. And a plan is notified of Rad V audit. CMS requests the records from the plan, and the plan sends in the best record they have to support the HCC reported. These records are reviewed. The audit results are concluded. Payment error estimate is developed. At this point, the plan can appeal if they have a basis for an appeal. And after that is the extrapolation of payment. Okay. So just a quick note on that. And again, you know, each of these slides it has much deeper learning associated with them. So let's say a health plan has fails a Rad V audit based on their HCC of diabetes. Okay, and essentially there's 201 records. In most cases, there's 201 records that are reviewed. Okay, and let's say the error rate of those 201 is 50%. Okay, but the plan has 1 million members. Okay, and out of 1 million members, it's reasonable to say that probably 300,000 have diabetes. Okay, diabetes is a very common disease, and I'm just making that number up off the top of my head. But so if we review 201 records and 50% have an error in the diagnosis category, okay, that's 100 errors, okay, but that would be indicative of a 50% error rate over the population of 300,000 that have the disease. So the CMS would assume that if you have a 50% error rate, that 150,000 people diagnosis were, or HCCs were misrepresented. So so on this audit, the findings are applied to the overall population, and it can become quite costly to plans in terms of reimbursement of premiums paid and possible fines and penalties. You can visit paymentAccuracy.gov and see the error rate, overall error rate for Medicare Advantage Part C. This is a requirement that the federal government reports this each year. Just to give you an idea, there are 3,142 counties or county equivalents in the 50 states, okay? And right now, about 34% of Medicare eligible beneficiaries are covered by Medicare Advantage, okay? So about a third of Medicare beneficiaries are covered by Medicare Advantage, and that number is growing. Has been steadily growing since the inception of risk adjustment in 2004, which was just 15 years ago. and it continues to grow for a number of different reasons. Remember the $900 multiplier we used in our sample risk score calculation? Okay, I mentioned that there are 3,142 counties and county equivalents. Okay, and that's important because each county has a different number that will be used in place of that $900. Okay, and you'll see here on one side we have Alaska, and on the other side we have Puerto Rico. Okay, and you'll see the county or county equivalent name, and so in both grids you'll see the state abbreviation, AK or PR. Next would be the county name. Next would be the rate. Okay, and you'll see again some of the figures in here. We certainly don't have time to drill down and explain all of them, but what you want to look at is that first column and use that as the multiplier for calculating a risk score for a beneficiary in these particular counties. So let's take a look at that. Let's look at if a member resides in Bethel County in Alaska. Okay, and let's look at their risk score. If their risk score was combined 2.392 from our 4 squares, we're going to multiply from, let's look at Bethel County is 110640. So we're going to multiply 110640 by the risk score of 2.392. And you're going to see the per member per month premium is going to be $2646.51. Okay. Let's say another member in Bethel County had a risk score of 6.023. Okay. Multiplying by that same number, the monthly premium paid for that beneficiary is going to be $6,663.85 per month. Okay. And let's just say there's a member in Bethel County who has no conditions, and we'll use the arbitrary risk demographic risk score of 0.381. The health plan is going to get $421.54 for a beneficiary of that demographic without any conditions. Okay. Let's go down to Puerto Rico, Arroyo County. Okay, and let's use the same risk scores and apply them to the let's go back and look. You see the Arroyo County multiplier is 433.56. So let's say the member that had 2.392 risk score, the monthly premium for that beneficiary in Arroyo County in Puerto Rico is going to be $1,037.08. Let's take a similar member who has a risk score of 6.023. The monthly premium for that beneficiary in Arroyo County would be $2611.33. And let's, for example, take a member that has no HCCs, just the demographic, and that would be 165.19 in Arroyo County. And this is calculated for every county in the country, depending on where the beneficiary is. But you can see how these numbers change based on risk score. And the risk score is completely dependent on documentation and coding from providers. So the key to successful risk adjustment is knowing regulatory guidelines, accurate documentation, accurate ICD-10 guidelines and code assignment, and accurate data submission. So I want to talk about a few other things. We talked about the Medicare Advantage Medicare risk adjustment model, which is an HCC model. Okay, and that's referred to as the CMS HCC model. Okay, back in 2014, actually prior to that, but it was implemented in 2014, President Obama said, "You all must have insurance. It is law," right? Well, if he was going to say that, he had to turn to the insurance companies and say, you must provide it. It is law. And so enter the age of risk adjustment in the commercial insurance realm. Okay. And for risk adjustment in commercial insurances, they adopted an HCC model, okay, that is similar to the Medicare model, but has distinct differences. And that is administered by HHS, Department of Health and Human Services. So we have the HHS HCC model and we have the CMS HCC model. And so I want to point out, for example, let's go back just to this slide for placeholder. A diagnosis that relates to pregnancy would not be included in the Medicare or the CMS HCC model, okay? Because the population is generally 65 and over. Yes, there are some who may be less than 65, may even be of childbearing age, may even bear children while on Medicare, maybe because of due to disability, being eligible due to disability, but it's not a significant enough of the population to include it in that diagnosis structure. But under the HHS HCC model, which covers beneficiaries from age 0 to 65, pregnancy-related diagnoses are included in the HCC model. So just an example of how the two models differ. The Department of Health and Human Services created a risk adjustment model based on HCC classification system. Okay, the Affordable Care Act required the use of different factors related to HCC. And the overall goal of these programs was to provide certainty and protect against adverse selection in the market while stabilizing premiums. So this was adopted so that that health insurers who were writing insurance for individuals were being compensated adequately for incurring more risk. So, up until then, health insurance carriers would deny coverage to individuals who had certain health conditions, seeing them as too risky, too costly. Okay, but risk adjustment alleviates that burden. Okay. The HHS HCC risk adjustment model uses individual demographics and diagnosis to determine risk score, which is a relative measure how costly that individual is, just like we demonstrated with the Medicare Advantage risk score. But the individual risk scores are averaged out against the population, and that's where the plan risk score comes in. And so let's say Aetna has a population risk score of 4.2, and let's say Cigna has a population risk score of 2.2. That's a full 2-point difference. So Cigna would have to contribute and subsidize to level out that difference in risk, and that's just a very, very rudimentary, illustration. You have many more plans involved, and they pay into a fund that out of that fund, the higher risk model plans get subsidies. The HCC risk adjustment model is a concurrent model, and it means that the look back period is actually during the current year, where the Medicare risk adjustment model will go back as far as 2 years. And in the HHS HCC model, patients are classified into 15 submodels, okay? Based on age, you'll see the top row, infant, child, and adult. And then metal levels, which are the level of coverage, okay? Platinum, gold, silver, bronze, catastrophic. I don't know if anybody has ever looked at or even possibly purchased insurance from the government health exchange. But when you go to look at coverage, you can select a plan that just covers everything. And they are identified by metal levels. So platinum is the highest, highest coverage plan, generally costs more. Okay. Gold, silver, bronze, and then catastrophic. Catastrophic is a bare bones plan that will, basically cover catastrophic loss, but has the lowest premiums, but more out of pocket costs. So you're basically paying for almost all your doctor's visits. Cover a severe hospitalization or something like that. And let's talk just briefly about some Medicaid models, okay? CDPS, Chronic Illness and Disability Payment System. Medicaid programs use this to make health-based capitated payments for TANF, which is Temporary Assistance for Needy Families and Disabled Medicaid beneficiaries. And CDPS is provided under license free of charge to qualified public agencies, educational institutions, and researchers. CDPS was developed by UC San Diego, University of California, San Diego. And it's all ICD-10 codes. There's different major categories similar to what we looked at in the Medicare model with 58 different CDPS categories. And they're hierarchical within major categories. Here are some of the major categories. Looks similar to the ones in the CMS model. And they're hierarchical. So in the cardiovascular category, we have levels of severity. Hypertension would be in the cardiovascular category, and it would be an extra low severity compared to very high, which would be like a heart transplant. Okay. And again, this is just kind of background information. Each of these models could be hours of training or study to understand. Clinical risk grouping is developed by 3M. It's a clinically based classification system to measure burden of illness based on claims data along with other data sources. And it's comprehensive and takes into account age, income, disability, severity of illness, frequency, and other factors. Okay, so 3M developed the CRG classification, and it is, again, based on risk, which is the common denominator for all risk adjustment models. Risk is the common denominator for all risk adjustment models. Okay. Each individual in the CRG, each individual is assigned to a base CRG that reflects the full range of diagnoses for that individual. Then there's severity of illness that takes that out to a number of different levels. So there are 9 health categories, 272 base CRGs, with an average of 4 to 6 levels of severity of illness. And so let's just take a look. You'll see diabetes, there's 4 levels of severity, CHF, 4 levels of severity. You have some interactions there, or combined items that combine conditions that take it out to 6 levels of severity. Okay. And so a disease profile and history of interventions is created for each individual. For each organ system, the most significant chronic disease under active treatment is identified. For each organ system, the highest level of severity is determined. So number 2 and number 3, the most significant chronic disease with the highest level of severity are combined to come up with an overall CRG. Okay, and so we'll just take a quick look here. All right, remember I said there were 1,080 CRGs. Okay, and this is how we get to 1,080. You'll see the 9 different categories, healthy up to catastrophic. Okay, and we have how many base CRGs for each category, and then the levels of severity. So there's 272 base CRGs from the 9 categories, And then based on levels of severity, it can be taken out to 1,080 individual CRGs. Okay, I'll give you an example. In the healthy category, there are 2 CRGs: healthy user and healthy non-user. Okay, a healthy user is a Medicaid beneficiary who had some type of interaction with healthcare services. Okay, um, and it may have been just a routine physical, no conditions were identified, but they did have a visit. Healthy non-user was somebody who was eligible for Medicaid and never had a healthcare encounter. Okay, so that's how we get 2 CRGs in healthy. Okay, and for each of the different 9 categories, there's some examples here. History of significant acute disease, single minor chronic disease, minor chronic diseases in multiple systems, significant chronic disease, okay, significant chronic diseases in multiple organ systems, and so on up to from the healthy user or non-user up to somebody who has, top tier, very severe conditions. Okay, and so again, this is just another model. This is the Medicaid model. There's several different Medicaid models. Right now, out of 50 states, about 36 risk adjuster Medicaid managed care plans. Okay, so I did mention the importance of this knowledge to medical coders because there is an impact on physician practices. Virtually all healthcare coverage now relies on risk adjustment. Okay, and trouble rolls downhill, right? So the impact on physician practices is this: most risk adjusted plans are managed care plans. Managed care plans are often contracts between the managed care organization and providers. Okay, so it's in the contract. Okay, folks, take any managed care contract that you have in your practice, if you work in a provider practice, and if you have it in PDF, you can just hit Control F and search risk, search diagnosis, search documentation, and read what your provider manual states as your obligations. Here is, we hear all the time, I've never heard of risk adjustment. I've never heard of HCCs. Folks, it's been in your contract for a very long time. For a long time, it was not under the RAPS structure. The health plans were taking on the burden of reviewing the records, and it really did not filter down to the provider level. Okay, under encounter data, the language that's in these contracts is going to be enforced by the health plans at the provider level. So another reason or another way that it's going to impact providers is, and this has been around since the beginning, but it is becoming more and more common. Almost, I see a day where every provider will be involved in a risk-sharing situation, and that is if the plan has success in its risk adjustment, providers will share in that success. If there's failures, the providers will share in the failure. Okay, so they're going to share that risk burden. Again, the impact on physician practices, reimbursement from Medicare Advantage plans. Remember the money tree. Okay, if providers want to see at least stable or growing reimbursement, it is in their best interest to assure that their payers are receiving all the premium they are due. If they don't, then it's going to impact the reimbursement rates. Quality and value-based payment evolution, audits, and quality of care ratings. Reimbursement from Medicare Advantage plans, whether capitation or fee for service, the rates that will be negotiated will be directly tied to the revenue the plan has to operate. Uniquely, risk adjustment provides mechanisms to increase revenue to cover more costly health conditions. The more revenue, the more likely provider reimbursement will reflect gains. What is certain is limited revenue will limit provider reimbursement. Quality and payment, value-based payment evolution. Okay. Perhaps you've heard of MACRA or MIPS or APMs. Okay. This all is interrelated. Okay. And one of the keys is effective documentation. And if providers document effectively, then that is going to be half the battle towards success in risk adjustment. Medicare Advantage plans accounted for 27% of all Medicare spending in 2016. This is a little dated, so it may be a little more, or $198 billion. Okay. Over 600 Medicare Advantage contracts exist, and it grows each year. And enrollment in Medicare Advantage plans is growing each year. Okay, so folks, this is not going away. This is only going to grow, and the responsibility of providers is only going to be greater and greater. And quality and value-based payment evolution. Within risk adjustment, there's the STAR program, and this comes from a number of different areas and assessments, but providers are a key role in that. And when beneficiaries are selecting a Medicare Advantage plan, the STAR rating is provided for the use of the beneficiary in plan selection. So the Medicare beneficiaries who are coming to your practice through Medicare Advantage plans, if the success of the plan is hindered by providers that are not that are barriers to achieving a highest STAR level, the beneficiaries will opt for different plans, and it may in fact impact provider patient access. And remember, audit from RAC to Rad V and beyond. Provider records are used in record reviews and audits consistently. Providers may not be aware to what extent or by what agency their records may be seen. However, we can assure you it is very extensive. Every Medicare every Medicare Advantage beneficiary, every claim, that information is reaching CMS. While records are ordinarily reviewed for the scope of the review and not used as an opportunity to mine for deficiencies, what is important is it's unlikely that official agencies will turn a blind eye to egregious errors or widespread patterns. And folks, I've said for pretty much for the length of my 30-year career, one of the best statistical capturing organizations on this planet is CMS. So your medical practice claims are reaching CMS, and they will not ignore patterns, okay, especially egregious errors or widespread patterns. So, the time for completeness and accuracy in documentation and coding is arrived. And one of the things about outpatient medical provider, medical office visits, etc. The focus has largely historically been on, the reporting of procedure codes. Hey, I want to get paid. I did this. I want to get paid for everything I did. And the focus has been procedure codes. And collectively on an outpatient basis, diagnosis coding has not been a priority. And risk adjustment depends solely on accurate reporting of diagnoses. So, and another reason why medical coders really should understand and be proficient in risk adjustment, and understand the pathway to complete and accurate diagnosis coding. And again, this is just a revisiting of the fact that CMS is implementing this encounter data process. Okay, and so what was largely at a level that did not involve the medical providers, the day is arriving where it does. I'm going to see if there's any questions from any of our participants. I see some compliments. Thank you for the great information. You're very welcome. Great webinar. Thank you very much. I don't see any questions. I'm going to give it a moment. And while I'm waiting to see if there's any questions submitted, let us go to the CEU process. If you have attended the live session, your CEU will be emailed to the email address that you use for the webinar. If you're watching this presentation on demand, then a post-test is required for your CEU, and so please complete the post-test. And it requires a 70% or higher. Multiple attempts are allowed. And once you complete the post-test with a 70%, you'll be able to print your certificate, your CEU certificate, right from the system. So that is our presentation, Introduction to Risk Adjustment and HCC Coding. We thank you for attending. Again, you are with Compliant Coding Systems Coding Academy. Our email is support@compliantcodingsystems.com. And so if you have any questions or would like more information on further training, please feel free to contact us. And again, we thank you for attending today's presentation. We hope you have enjoyed it, and we hope that you will advance your knowledge in this key area. Thank you, everybody, and be well.